Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
If you've been told that you or a loved one needs heart surgery, you're probably wondering exactly what that means. You know, for most of us, our first thoughts are about open heart surgery. They crack your chest, they fix whatever is wrong inside, they sew you up, and you're probably in for a pretty long recovery. But for a lot of people, there is now an alternative, and it is called minimally invasive heart surgery. In minimally invasive heart surgery, also called robotic surgery, your surgeon makes one or more small incisions between your ribs, and then surgical instruments along with a tiny camera are inserted through those little holes. Pretty cool.
The surgical tools are connected to robotic arms that the surgeon controls with a computerized device. Who is a candidate for minimally invasive heart surgery? What procedures can be done using that robot? And what is recovery like? We're going to find out. Joining us in studio is the chair of cardiovascular surgery at Mayo Clinic, Dr. Joe Dearani. Welcome back to the program, Dr. Dearani.
Well, thank you. It's nice to be back.
It's always good to have you. This has got to be pretty exciting for you and your colleagues.
Oh, yeah. I mean, the advances in cardiac surgery day to day, week to week, and year to year, it continues to be a specialty that really pushes the envelope in terms of trying to implement new things. And we're doing a lot more with cardiology now. A lot of procedures, these minimally invasive procedures, are done in conjunction with them. Yeah, it's exciting. It's an exciting field.
When you started doing heart surgery, 20 years ago?
Yeah, that's right.
Did you ever imagine that you'd be doing it this way?
Well, the minimally invasive thing, you made the reference to robotic, and robotic is one method of minimally invasive surgery. Minimally invasive surgery refers to doing sort of a standard operation through a very small incision, and sometimes that small incision doesn't require the need for a robot, but the really small incisions are helped with a robot. And so I would say that many of the minimally invasive cardiac surgery procedures that we do here at Mayo do utilize the robot, but there are some others that we do that may require just a small incision in the front or a small incision on the side that you can do with a camera or without a camera and without the robot. So it's a lot of options out there.
Aside from sounding absolutely horrible and terrible, what is wrong with cracking the chest?
Well, crack is a bad word. For surgeons don't like that word, crack.
I shouldn't have said that.
But,
yeah.
But no, I think that, of course, the less invasive it can be, the lower the potential problems. Less bleeding, less likelihood for infection. It makes the challenge for the surgeon to do the operation a little more difficult, but with the improvements in technology and instrumentation, we do have the means to do essentially the same operation through a much smaller incision. It always needs to be left to the discretion of the surgeon, and I do think that while I think the most important message for the patient and the public is that it still is a requirement that you do the proper operation, and I would not compromise the proper operation for an incision that's a little bit smaller. I mean, that's not a good trade, but if you can do the proper operation through a smaller incision, and we can for many, then it's a good thing for patients, it's a good thing for the doctors and surgeons, it's a good thing for the recovery, it's a good thing for society with people getting back to work earlier and so on and so forth.
So just think about it a minute. They take a saw and split your sternum.
I don't want to think about it.
Crank it open, do the procedure, pull everything back together, and then do you still wire the sternum back together? And then that has to heal.
Yes, if we are going through the sternum, we use wire, and that has to heal. And you know, most bony injuries, whether they're surgical or whether accidental, we usually still take about 6 ± weeks before they heal. Still, yeah, so it's a gold standard, and it's we've been doing it since the 1950s, and there are many, many, many wonderful, solid operations that we do with many, many years and decades of follow-up by going through a sternotomy, and that, at the end of the day, is the most important thing that we offer.
The exposure's a little better, that's for sure.
The exposure's better, and you can handle any potential problem and so on.
And when you say robot, tell us what you mean by robot.
So one of the advantages, so you start with a very small incision, but then instead of trying to put instruments through that small incision to work, there are other port sites that are basically like the size of a Bic pen. And usually there's 3 of them where the arms of the robot go in. So you have the arms of the robot, and at the end of the arm is a surgical instrument, whether it's a scissors or it's a needle driver or it's a forceps. And so the beauty of the robot is that they're so sophisticated. It's basically a very expensive computer.
Yeah.
And the movements are very, very fine. And so you have the ability to do very, very fine, delicate surgery through really teeny incisions, because you're not fighting the much longer instrumentation that your regular hands would need to drive. Now they're very, very fine, very small, narrow instruments that with very, very fine, accurate motor control.
What I don't understand about robotic surgery or about minimally invasive surgery is, if you can do some heart procedures, why can't you do all of them this way?
Yeah, that's a great question. So when we do robotic heart surgery, the incision is on the side of the chest. And so when you do an incision on the side, that only allows you to do a shorter list of procedures because you don't have access. So for example, the aortic valve, which is in the front, or coronary surgery, which may require you to be in the left side and on the bottom and in the front, you wouldn't be able to do all that through one little incision on the side. So certain procedures lend itself much better for a minimally invasive approach.
Why can't you do these small incisions just right above the heart on the chest, right on the front of the chest?
Well, it's a great question. The advantage of going through the side is that the anesthesia team can collapse the lung, and so you have this big space where the arms can go in and move around. Trying to do that in the front with a robot, you can't do it, which is one of the reasons why you can't even use the robot in very small children, because there's not enough space in the chest, even when the lung is collapsed, for the arms to sort of move around.
I guess you got that breastplate there too.
Right.
Same
Right.
problem
Right.
as a traditional surgery.
Exactly.
And how do you control these robotic arms?
Well, they're controlled with a console. Again, it's a very sophisticated computer. So at the bedside, you have the robot, which is the instrument that mans the instruments that you actually put into the patient. Then there is a console. It's like a cockpit that sits in the corner of the room.
That's where you are?
That's what. Well, there's one surgeon there, and there's one surgeon at the bedside, because somebody has to pass stuff in and out, sutures and valves or whatever it is that you're doing. Some of the knot tying occurs at the bedside because it's a little more efficient than the robot doing it. But the visualization is really unparalleled. I mean, and everybody in the operating room can see it because there's multiple screens around the operating room. So as an educational tool, it's really probably the most powerful way to teach someone, because everybody can see exactly what's going on stitch by stitch and step by step.
Did you have to, having done everything open in your first part of your career, how long did it take you to learn to do this? I mean, and if you had played computer games as a kid, would you have been better at it?
Well, you bring up a very, very good point. And right now, at the society level, we are trying to understand what the best training paradigm is for people that want to do minimally invasive and robotic surgery. Now, I think I actually come from a background that sets yourself up the best for minimally invasive surgery, and that is someone who has historically done all of these operations open. So you then have a full command of the operation. You know where all the pitfalls are. You know where all the steps are that you have to be careful where you could do something harmful. And then it's just learning the technology of the robot. And I think that's the disadvantage for people that are just coming out of training. Is, one of my mentors said when we started the robot, he had said, make sure that you have complete ownership and command of the open operation so that you can deal with any of the troubles that you encounter with the robot. And for the new grad, they don't have that learning curve under their belt yet. They may be a little bit better with the technology, but as you know, as a surgeon, you need to be a critical thinker, you need to have judgment, and you need to have technical ability, and you need to have intellect, and all that stuff needs to sort of work together for this to be successful.
This is going to be a problem then for these new students, because if the way that you learn is by doing it through the traditional way, you're not doing that anymore.
No, you can learn. I think the learning curve is just a little longer when you're trying to get into the game as a new grad. Where the learning curve for somebody who's a little more experienced, it's really just learning the technology. And some people may be better than that or not. You know, I spent a lot of time in the evening hours coming in and sitting down at the simulator and practicing with it. But, you know, it's like everything else. You practice, you get better at it. You practice more, you get really good at it. And the more you practice, you can get great at it. And it's just all about hard work and discipline.
How often does it happen that you are doing something robotically, or you plan to do it robotically, and you have to switch gears? You say, you know what, we got to open this.
Rarely. And the reason why that rarely occurs is because the screening and the patient selection processes that are in place beforehand allow you to have to rarely do that. And so we've learned, you know, there's body habitus issues. Some people are too small and there's not enough space for the arms. Some people are too big and the arms don't reach, you know, in an easy manner. We do this CT imaging of the chest and the abdomen and the blood vessels in the groin because we still do need to connect to the heart-lung machine. So we want to make sure that we don't have, you know, patients with unrecognized coronary disease or vascular disease that would make the use of the heart-lung machine in the leg dangerous. So we have a screening process that we're relatively strict with. So the patients that we pick from the beginning you're very, very confident. And when we have a patient that is on the borderline of whether or not they would be a candidate robotically, then we have 2 staff surgeons evaluate everything and both need to agree to do it so that you really are sort of optimizing success. So we've done just about 1,000 robotic mitral procedures here now.
1,000?
Yeah, just about 1,000.
So the mitral valve, you've replaced it or repaired?
Most of them are repairs. I mean, I would say that 99% of them are repairs. There's been a very short list of replacements because most of the time you can repair the mitral valve. But it's been less than a dozen times that we've had to convert or open, and maybe even less than 5. It's very, very rare, and it's for an unexpected complication that you're always prepared to deal with.
All right, the chair of cardiovascular surgery at the Mayo Clinic, Dr. Joe Dearani. Keep the heart beating. We need to take a short break. When we come back, we'll talk more about the benefits of minimally invasive heart surgery and also the complications. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are with the chair of cardiovascular surgery at the Mayo Clinic, Dr. Joe Dearani. We're talking about minimally invasive robotic. Well, there's actually a little bit of difference, minimally invasive and robotic heart surgery. So what procedures can you do robotically or minimally invasive?
So the most common robotic procedure on the heart is mitral valve repair, followed by mitral valve replacement. But in this country, mostly mitral valve repair because valves can be fixed, that is saved, preserved, the patient's own valve, and that's really what they want.
Why do you say in this country?
Well, I think that when you get to other countries, rheumatic valvular heart disease is much more prevalent, and those valves are more difficult to repair, and you're more likely to need to replace them. But we don't really see much rheumatic fever in this country because of antibiotic therapy and access to good health care for pretty much all citizens.
Remind me and our listeners, where is the mitral valve? What does it do, and what goes wrong with it? How can you repair it?
So the mitral valve is a valve inside the left side of the heart. The left side of the heart is the side that gets all the oxygen-rich blood from the lungs and pumps it all to the body. And the mitral valve is the valve in between the lungs and that main pumping chamber. And the most common abnormality in this country, in North America, and mostly in the developed world, is what we call myxomatous degenerative mitral valve disease, where the leaflets get floppy and the strings that support the leaflets get elongated and they either stretch too much or they actually break. And when that happens, you end up with a problem where the valve leaks. So it's a leaky valve problem. And
so that then when the left ventricle pumps, it pumps blood not just to the body, but part of it goes back up into the left atrium.
Yes.
It goes backwards.
It goes backwards toward the lungs, and this is why patients will feel fatigued and shortness of breath and have trouble getting their breath, particularly when they exert themselves.
Okay. Why does that valve, is that valve more complicated than others, or why is it that one goes bad so often?
It's that valve is just a setup for that particular problem. The anatomy of the valves inside the heart are a little different. The aortic valve, which is another valve with a common problem, where you get narrowed or leaky, there are no strings to that valve. Those are just little semilunar cusps. So different problem.
All right, mitral valve. What about coronary artery disease?
You can do if a patient needs multiple coronary bypass grafts, they need a standard operation. If they need just one bypass graft, and there are some situations where that's the case, you can do it robotically or you can do it minimally invasively. And then the cardiologist may be able to put stents in the other smaller arteries so that you're saving a big incision, and it's what we call a hybrid procedure, part surgery, part angioplasty with stent.
And that would be a coronary artery that's not stentable for whatever reason.
Well, not necessarily. The big, all of the literature and data shows that the big artery on the front of the heart, the one that's often called the widowmaker, that artery, when you use the internal mammary artery underneath the breastbone to bypass that artery, that's been shown in many studies all around the world. There is a big survival benefit when you do that. So when that artery is involved, there is stronger consideration to doing bypass surgery, particularly if they're a diabetic or they have other arteries with narrowings. When it occurs in isolation, the minimally invasive approach is really could be quite ideal.
Well, it's a lot easier for parents. It's a lot easier for patients for their recovery. What is the difference in the cost?
So there is it's more expensive in the beginning because you have to buy the technology. And we looked at this in our own practice. And in the beginning, it's more expensive to do it robotically. But after you get through the learning curve and everybody's up to speed, then it ends up being less expensive. And it ends up being less expensive mostly because the length of stay in the hospital is less. So the typical length of stay for a patient having robotic heart surgery is 3 to 4 days, in contrast to 6 days, sometimes 7 days when it's done open. And the recovery to full activity is usually 3 to 4 weeks as opposed to 6 to 8 weeks. So everything is cut in half.
I know you have a special interest in treating kids. Do you ever use robotic surgery on young children?
Well, I would say that they need to be a certain body size. So we've done robotic heart surgery in teenagers. And, there are some teenagers that happen to be big and tall, and there are some that are too small. And it all comes down to what the lesion is. The abnormality in children that lends itself to the robot is a hole in the heart. And many of these holes can be closed in the cath lab with a catheter, but there are some where the hole's too big and they can't. And those are the ones that we've done with the robot. So we've done a number of teenagers with the robot. They just need to, it's all a body size thing. They need to be big enough, and there are many that are.
So the hole is inside the heart, between the chambers?
Between the chambers, exactly. And they usually get closed with a patch.
Can the technology get better? Can the robot get smaller?
Yes. The technology can get better, and there is a lot of work going on in advancing the technology to a point where it could be applied to, smaller patients.
So most of the kids that you operate on have a congenital abnormality. Is that correct?
Yes, they're born with something that's abnormal.
What's the youngest child you've ever operated on?
Oh, we operate on newborn babies.
You do?
Oh, yes.
And how do you know there's something wrong?
Well, many mothers will have the benefit of prenatal ultrasound. So most of these defects are picked up with a prenatal ultrasound. They get followed during their pregnancy. And, the ultrasounds that are done can be quite good. I mean, you can get pretty good clarity of what you're dealing with so that you know what to expect after birth. And sometimes it's an anomaly that's going to require surgery in the first few days of life. Or it may be an anomaly that can wait till they're 6 months old, or maybe even later.
How big is the heart in a newborn?
About the size of a golf ball.
And you use loops? I mean, you use magnification to work on these kids?
Always.
It's all pretty incredible, isn't it?
Wow.
Dr. Joe Dearani, Chair of Cardiovascular Surgery at the Mayo Clinic, minimally invasive heart surgery and robotic heart surgery, truly a major advance for multiple heart conditions. Less pain, quicker recovery, shorter hospital stay, higher initial cost, but long-term better. Thanks for joining us, Dr. Dearani.
Well,
Good
thank
to have
you for having me again.